Thank you. Okay, I'd just like to introduce Marcia to people today. I've known Marcia now for over 10 years, off and on, meeting her here and overseas, and I have always been amazed by Marcia's commitment to healthy and active lifestyle for older people, and her just sheer enthusiasm for what she does, her energy and her capacity to give, and always ready to talk and give to people. So I'm really pleased to welcome Marcia today. She has an incredible history of doing things, so I'm actually going to read a little bit about her profile because she is such an amazing person. Marcia is Regents and Distinguished Professor, Department of Health Promotion and Community Health Sciences at the School of Rural Public Health at the Texas A&M Health Services Center in College Station, Texas. She's also the director of the program there on healthy ageing and the academic partner for the Community Research Center for Senior Health. She's involved in 2 special initiative projects funded through the Centers for Disease Control Prevention Research Centers, the Texas Healthy Aging Network, and the Central Texas Cancer Prevention and Control Research Network. And she serves as the evaluator for the statewide Texas Healthy Lifestyles Program. She's active in many professional organisations and on a number of task forces, and co-chairs the new Exercise is Medicine Aging Committee. Primary investigator on multiple local, state and federally funded grants to implement and evaluate evidence-based interventions for promoting healthy lifestyle changes in midlife and older ages. As the National Program Director for Active for Life, she documented the success of behaviourally based exercise programs for increasing physical activity in Americans 50 and older. She currently directs the Texas Department of Aging and Disability Service adaptation and evaluation of the Texercise program and oversees the local implementation and evaluation of the evidence-based Fit and Strong program. Drawing upon a life course perspective, she has also been a primary investigator on several research studies exploring policy and environmental interventions for reducing childhood obesity. In these roles, she is examining how health promotion evidence-based programs for individuals at different life transitions can be translated to clinical, community or workplace settings. Previously, Marcia spent 20 years in federal services as Chief of Social Science Research on Aging in the Behavioural and Social Research Program in the National Institute on Aging, the National Institute of Health. She holds a doctorate from Purdue University and a Master's of Public Health from Johns Hopkins University. She's been the author of more than 250 publications on a variety of topics, including self-care, physical activity and mobility, doctor-patient interactions, chronic disease management, obesity prevention, falls and injury prevention, women's health, minority health and translational research. So I'm very pleased to welcome Marcia today, who's going to talk specifically today on the falls prevention initiatives that have been rolling out in the United States, where she's involved in independent evaluation of these programs. So, thank you, Marcia.
Thank you. I'm absolutely delighted to be here. I've already had an opportunity at lunch to meet what I would call local experts, and you've heard a little bit about me. What I'd like to know is who I'm talking to. So how many people in the audience are students? How many people are faculty or staff here at the university? Excellent. And are some people in local government? What are some of the other areas you represent? Just shout it out. Pardon? Public health? I love public health. That's my area. Other areas that people are in? Say that again? Physiotherapy, excellent. So clinicians are in the room. Other kinds, pardon? Aged care, charitable institutions, and just one more kind of area that's being represented. Veterans Affairs, so all really important. Hopefully what we all have in common is working and wanting to know more about falls prevention. And as Lindy said, what I'm going to be talking about are some national initiatives, and mostly ones that are supported by the Centers for Disease Prevention and Control. So one of the things that we think about is that, falls prevention, the key word is that falls are preventable. But it really takes a multifactorial approach. And this is what CDC and others think, and I'm sure it's the same kind of things that you think here in Australia, that you need to think about policy and systems changes. You need to think about community programs, and particularly evidence-based community programs, and then clinical interventions, clinical interactions. So all three of these are important toward falls prevention. I'm going to talk about these special initiative projects, and we call them SIP. And I actually have two of these, SIP 1 and SIP 2. And this just gives you a sense of the questions that they ask the evaluation team. On SIP 1, and this is called State Falls Prevention Program, the specific question was, if we have multi-level programs in place, can we reduce falls-related injuries by 10% over 5 years? Is that a goal that people think is achievable? Well, we're in about year 3, and we don't know, but the whole point is to set a big goal, one that will have you reach toward that goal. SIP 2 was slightly different. In a moment, I'll describe that. Its title was Policies, Programs, and Partnerships for Falls Prevention, and it asked a slightly different question. How do we facilitate the adoption of falls prevention programs and practices by all key stakeholders? So actually, SIP 1 started 3 years ago, SIP 2, 2 years ago, so they're still relatively new. Let me sort of talk about how they fit together. So if you look on the left, SIP 1 focuses on building capacity and outcomes in 3 states. These were 3 states of 3 injury prevention centers. We're working in New York, a huge state, Colorado, one of the states in the middle, and Oregon. So 3 states that have very active injury prevention control. On the other hand, what we do at SIP 2 is we're again looking at the adoption, the implementation of these policies and programs that are being broadly disseminated. So on one side, we're looking at 3 states. On the other side, we're looking at all the nation, like if you think about it, all 50 states. So SIP 1 focused on a wide range of interventions. Remember, I showed you the Venn diagram. You could see community, clinical, and policy. For SIP 2, we're zeroing in on the statewide policies and coalitions. I'm actually going to talk about some of the stuff we're doing there. Otago, which is one specific evidence-based program. I'll talk about that. And then community health workers. Do people here have the concept of community health worker? It might be called something different. Sometimes it's called lay health leader. It's a person who is sort of between healthcare provider and people in a community who are known and respected and trusted in that community, who serve as an intermediary role. On the left, what we wanted to do was to begin to identify both our process and outcome measures, and then in SIP 2, we would build on those that we identified. In SIP 1, we focused specifically on these 3 state injury prevention programs, whereas we had broader level of stakeholders in SIP 2, that is the state falls prevention coalitions and people who would actually be delivering falls prevention programs, whether they were physical therapists in the case of Otago or community health workers, as well as the program participants themselves, and these were older adults at risk of falling. So let me talk a little bit about SIP 1. Remember, this is State Falls Prevention Program. We wanted to evaluate 4 different approaches to falls prevention. Stepping on. How many people in this room have heard about stepping on? I want every hand to raise. Lindy wants every hand to raise because that is a homegrown Australian program. Tai Chi. Are you familiar with Tai Chi? Okay. Otago. That's your neighbor, New Zealand. How about Steady? That may be less familiar. Steady is a program that works specifically with healthcare providers, particularly doctors. So let me just sort of go through, for those who don't know, the different programs. Stepping On, developed in Australia. Lindy, you and your colleagues should take a bow for this. What they did for the CDC is they picked out 3 programs that were all evidence-based. And there's a compendium, and the compendium is programs that work, and CDC has this, and the 3 that you'll see are all in the compendium. Stepping On made it because it had shown in rigorous trials about a 31% improvement in fall reductions. If you know about the program, it's offered once a week for 7 weeks. It utilizes the best of adult learning, self-efficacy principles, and usually taught by 2 trained workshop facilitators with these backgrounds. The adaptation is sort of changing this a little bit. So it was developed in Australia, but now there is a translational dissemination unit in the University of Wisconsin, and they work really closely with Dr. Clemson. So you have the classes, but like many programs, it's just not the classes. You realize the importance of follow-up, whether it's follow-up phone calls or booster sessions. And these are the people who are being targeted, those who have a fear of falling or they've fallen 1 or more times. Let me go to Tai Chi. This is Tai Chi, moving for better balance. And these are group-based exercises that focus in on 24 of the Tai Chi forms that really focus on weight shifting, postural alignment, and coordinated movements. In the clinical trials, it was shown to reduce falls by 55%. This is a different sort of duration and intensity. It's offered 3 times a week for an hour session, and the original was more like 24 weeks. The one that we're testing with CDC is actually a 12-week model. It was designed and tested by Fusang Li, and now it's been adapted and standardized by CDC, and they've done master training through the WISE. And so for each of these 3 programs, you can look on the CDC website, and they will have implementation manuals. Let me talk about Otago a moment. Again, this one is individually tailored. It's in the home, home-based, and it's by either a trained nurse or physical therapist. What we're doing is physical therapist-oriented. In the original clinical trials, it reduced falls by 35%. It started off in New Zealand, but it again has been adapted to American settings by Tiffany Schubert at the University of North Carolina. What you have is a series of leg strengthening and balancing, retraining exercises, and progression is part of this. And it's over 52 weeks. When we implemented this, one of the most interesting facts was who gets into these different programs. And so we started off thinking with Otago we would get people who were discharged from hospital, but they weren't able to benefit from these exercises. So we have a whole sort of inclusionary criteria. You have to be strong enough where you can benefit from the program. So often PTs do basic reconditioning, and then you get into Otago. And again, the program is adapted, standardized by CDC, and here's a copy of where you can get the final manual. I'm assuming that these overheads will be available for people. Good. So STEADY is stopping elderly accidents, deaths, and injuries. And it's really a toolkit that will help healthcare providers in fall screening and referral. How many people had the pleasure of meeting Judy Stevens when she came over to Australia? So some people did. She's really the sort of emphasis behind this program at the CDC. But it starts off with patient self-assessment for falls. Then it is clinician evaluation of gait, lower body strength and balance. There are, for physicians, case studies and ways to start the conversation about screening. A huge aspect of this is referral, so that the physician assesses and refers. And then there are educational handouts for patients. And so again, here's the place where you can go and get the study toolkit and all of the handouts. What's interesting is to think about STEADY as being physician-based. So the goal, CDC would love to see every single physician in America in primary care be knowing about STEADY so that they could do initial screening and initial referral. And it integrates with these community-based programs that I've talked about, whether it's Tai Chi, Stepping On, or Otago. So again, it's a unified, integrated community clinical approach. We think about this as having multiple partners. So we have multiple kinds of interventions, but this initiative also has multiple partners. I represent FETA. FETA is the Falls Evaluation and Technical Assistance Team. We work with many different partners. We have a national advisory group, and Lindy is one of our advisors. We work with the program developers because we think it's so important for the program developers of whether it's Stepping On or Tai Chi or Otago to sort of be involved in the rollout and the broader dissemination and translation. We work really closely with the CDC. In the case of the state falls prevention, remember I said we work with 3 states, so we work with 3 people who represent the state grantees. The orange box is I'm also a member of this group. This is the Healthy Aging Research Network of all people who are very concerned with aging and specifically concerned with physical mobility and falls prevention. This is only to show you, and think about this more in terms of when you see the actual PowerPoint. What the CDC believes very much in are logic models. You don't get funded unless you have a logic model. Is that something that is in Australia? Well, if the ante ever goes up, and I'm now looking at people from the Ministry of Health, if the ante ever goes up about logic models, you'll get the idea that they all have the same format. That is, inputs. What do you bring to this project? And here we bring the CDC, the different grantees, partnerships, and data. What are the activities? And here you see the evidence-based programs, the 4 that I mentioned, Tai Chi, Otago, Stepping On, and STEADY. You see the sort of outputs about what you expect people to do. That is to have programs being implemented, collaboration with all kinds of partners, standardized training, policy briefs, summary of data. And then you think about outcomes, and we think about short, medium, and long outcomes. So this just gives you a sort of sense of what the logic is, why we think this multifactorial approach will get to the long-term outcomes. We want the decrease in falls-related injuries and deaths. And remember I told you our goal was a 10% reduction over 5 years. We want a reduction in cost. We all know how expensive falls are. We want to have a positive return on investment. So we want these interventions to sort of save money. We want to create organization and systems changes. And we really want to have the dissemination of standardized materials. So let me move on to the sort of seeing it in a different way. We're looking at long-term outcomes in terms of system changes. And we think about this in terms of policy. There's big P policy where you think of legislation, but there's small p policy, like what you would expect hospitals to do or what you would expect people in primary care to do. I already talked about injury data, the goal of reduction in injury rates. And the only way that that's going to happen is if you have enormous penetration. And so for the state falls prevention program, we're in states, but we're not in everywhere in the state, but we're in pockets. So we'll be looking in particular counties. We think that's more reasonable. It would be very hard to mobilize up and think you were going to make a difference at the whole state level. And then again, cost is important. And part of cost is understanding what these programs cost to deliver. And you need that piece. Then you need to be able to cost out your gains. And then you can do cost effectiveness or cost benefit analysis. The intermediate goals, and that's really where we are now, is to look at reach and representation. So that is, how many people are we reaching? How many older adults are we reaching? And what are they like? Are we reaching those people we intend to reach? And so whether we're talking urban, rural, or people from different ethnic backgrounds, or people with different functional status, that's what the representation means. We also know to make this work, we need penetration. And to have penetration, it means we need to have program infrastructure. So all of these programs have certified trainers. They have a whole training infrastructure. So it goes from being certified as a master trainer, then teaching and training lay leaders. So we're also documenting how many trainings we're having, how many people are being trained. And it's not only how many people are being trained, but it's how many people are being trained and able and willing to offer these classes. In the past, what we realize is we often train a lot more people than people who actually deliver the courses. So we've gotten smarter in targeting those people we train on the front end. We have health and health belief benefits, and in this case, it's been positive in our preliminary data for our pilot studies. And these are the kinds of self-assessed health, the how do you rate your health, as well as people's confidence in health and their ability to prevent falls. And then functional status. And here, in general, for the community programs, we're using the time get up and go. For Otago, we're using many more of the functional measures. And again, our initial results have been very positive. So this is just a different way of looking at this sort of questions. Does a county-wide multi-level falls prevention intervention change county-level rates among older adults? And if so, how much and for whom? That's a basic long-term question. What is the cost of delivering these programs? We need to understand that. Obviously, a program like Otago is going to be much more expensive because it's one-on-one physical therapy. Probably next would be Tai Chi because of its additional training, and then you think about stepping on. Steady is something that we're trying to embed in ongoing clinical practice. For the third one, what organizational changes, systems changes, and other practice and policy changes have occurred? One of the issues and the difficulty with Otago is reimbursement. And so what we're seeing is, and for Steady, will the federal government reimburse for these falls prevention initiatives? And how can you tap in to some of the reimbursement codes that aren't being used now, but that could be used for falls prevention? The fourth one, the Aqua one, what falls prevention infrastructure has been established, and program implementation and maintenance, dissemination of materials embedded into injury centers and partner organizations. So again, it's having the infrastructure, embedding it into as many organizations responsible for the health of older people, and particularly falls prevention. Intermediate outcomes. Does a community-based falls prevention program improve self-efficacy to prevent falls among participants? We've been in the field for 2 years. We've just sort of finished our pilot data. The answer to this is yes. Does a community-based falls prevention program improve self-assessed general health status? Again, the answer is yes. Does a community-based falls prevention program decrease difficulties in carrying out activities among participants? Does it decrease the frequency of activity restrictions? If so, to what extent and for whom? We're not yet powered for this, so we've seen improvement in the right direction, but we haven't necessarily seen significant differences. And then does the program improve functional performance among participants? And we have seen this so far for both stepping on and Tai Chi. Other intermediate outcomes, does providing care providers with falls risk assessment, treatment, and referral result in increased provider adoption of the intervention? Does adoption increase over time? We are just now trying to get embedded in a few clinical settings. So we're learning what it takes to implement steady. We've not yet gotten what we would call adoption on a wide-scale basis. Does steady result in increased provider referrals? We think yes, but again, we're just at the very beginning stage. Increased engagement of policymakers. We're working on this through our State Falls Coalition, and attention to falls prevention by professional associations. Certainly the PT, the American Association of PT, has been incredibly active in terms of falls prevention awareness and also the dissemination of Otago. So we've definitely done that. Let me talk a moment about our policy toolkit. What this is several years ago, and this is really a 5-year process where you start off with a National Falls Prevention Action Plan. So there's a national action plan that you can see on the NCOA website. If you think that our logic model was complicated, you haven't seen the falls-free logic model, but it's also on the web, and it is excellent in terms of who needs to do what to accomplish what. But what this toolkit is designed to is really to give state and local coalitions ideas about strategies, tools, and resources for falls prevention. And I'm going to sort of go through this to help visualize it. So if you look here, this is a recent map. In green is where you have state falls prevention coalitions that are active. You have some in the South that initially had falls prevention coalitions, but for whatever reason, they're no longer active. And look, there are just only there's only 7 states that don't have a falls prevention coalition. And I think this is really credit to Lynn Beatty, who is a physical therapist who's at the National Center on Aging, who's really worked over the last 5 years to get states activated. So what are our targets for effective change? You can think about policies, and again, this is often, people think about laws or regulations, standardized institutional practices. You can think of systems changes. And so here's where you have procedures and protocols within institutions or networks, again, with the same goals. You can think of environmental targets, where you can create both social and physical environments that promote healthy choice, reduce falls risk. You can think about communication and media, where you raise awareness, you strengthen the social norm, and here we want that social norm to be falls are preventable. And then you can have, the target can be program and service delivery, where you have a variety of clinical and community-based programs that are evidence-based. So if you think about the falls-free policy goals, there are 8 of them, and I'm going to give you some examples, but let's just do an overview. The first one is to increase awareness. The second one is to increase provider participation. Third, to increase funding opportunities and investments. Fourth, to enhance data, surveillance, collection, analysis, and systems linkages. Fifth, to increase the availability, the accessibility of community programs and services. Sixth, to build and leverage an integrated, sustainable falls prevention network. Seventh, to improve fall prevention activities in places where older adults reside. And last, to institute ongoing evaluation of state efforts and outcomes. So these are the goals that we think will get us to more of a falls-free country. So there was a webinar, and you can actually see the webinar, and so I really attribute the next set of slides to my 2 colleagues, Lynn Beatty and Ellen Schneider. Do people know them? People want to know them, and there's actually a picture, I think, later on of Lynn Beatty. So if you think about, again, what is the purpose of this toolkit? It's to give states and local coalitions strategies, tools, and resources that can make their goals happen. It's to offer all kinds of suggestions about policy changes to advance falls prevention. So people no longer need to say, I'm interested in falls prevention, but I don't know what to do. There are lots of ideas about what can be done. And again, it's to be able to have these strategies and targets so that you can engage key stakeholders. So 8 overarching goals, policy changes, strategies, some examples I'll give. They actually have, but we don't have time to go over it now, both suggested indicators, how do you know you're having success, as well as select resources. So here's goal number 1, increase awareness of the issue and effective prevention strategies among stakeholders. And so the policy change here is really a statewide awareness campaign. And lots of states have done this. What they do is basically have statewide proclamations each fall for Fall Awareness Week. And they get the governor to sign it. They'll get the mayor to sign it. So it's really terrific because it raises awareness. In Australia, are people doing this? Is there something like Falls Day and these kind of proclamations? So similar strategy, very effective. A second one is to increase provider participation in falls prevention practices. And a policy change may be to link state and local health departments with clinical delivery systems. And this will help promote falls referrals and services. So a concept here, one strategy may be you get older adults who present at the emergency room for a fall-related injury. They may not be admitted, they may just come in for an x-ray, but instead of sending them home, you schedule them for a home visit with a PT or another healthcare professional who can do more falls risk screening and then get them into evidence-based program. This is working in Maine. Another goal, I think maybe I missed a goal. Nope, okay. Another goal is to increase funding. We all know that falls is an incredibly important problem, but funding is always an issue. What they want to do is to get state departments to have in their budget request that they will incorporate falls prevention activities. So there's a funding line of state departments, and particularly state departments on aging, have a funding line that comes from the federal government, but they don't necessarily use their money for falls prevention activities. So a strategy would be to have the state units on aging require the local area agencies on aging budgets to include falls prevention programs and activities. Right now, the budgets include things like Meals on Wheels, or there's even some money for health promotion, but not specifically targeted to falls prevention. So it's having these public health departments, on one hand, having the aging network require that this come down their budget line. The other would be having the Department of Public Health require that the local public health departments also include and plan for falls prevention programs and activities. Another one is all about data. It's, enhancing data, surveillance, collection, analysis, and system linkage. So it's, we know how important falls are. We also know how important it is for legislators to understand falls. So a policy change may be to create an easy-to-read annual falls report that goes to the legislature, to look through the existing data and develop a template for an annual report. Well, this is a template that the people in Florida did. It's an example of using data to go back to legislatures. Another goal is to increase the availability, the accessibility of community programs and services. And here it's so important to understand the evidence-based programs. And we now have many evidence-based programs. I talked about Stepping On, talked about Tai Chi, Otago. There are some that are specifically more physical activity oriented, like enhanced fitness. But to have these programs available in the community so that you have a menu of different programs, because you want to get penetration, different people like different programs, and organizations find it easier or harder to implement one program over another. Another goal is to build and leverage an integrated, sustainable falls prevention network. And again, it's having the state coalition leadership set priorities about building and sustaining their falls prevention network within their state. So it's always looking for opportunities to partner with other coalitions and organizations. So it's injury partnering with public health, injury partnering with aging, whatever the appropriate venue might be, to get more stakeholders involved and engaged. To improve falls prevention activities in places where older adults reside. And so this is really looking at falls prevention across the whole continuum of care. It's care for people who live independently in their own homes. It's people who are starting to live in assisted living units. It's people who are living in nursing home units. So it's really partnering with people, for example, the state geriatric care managers, or the state hospital units, or nursing home associations, assisted living associations, to sort of build in falls prevention into standards and policies. Evaluation is so important, and this is the last goal. And that is to really have a system in place that will not only develop and implement these efforts, but also evaluate, so you know what the consequences of the money that you're spending is. So again, there's an evaluation handbook for reference that you can see. Resources. We talked about how important money is. Each country has a different system. In this system, it would be Medicare or Medicaid reimbursement. So there's a tool sheet about that. Or how good of an investment community falls prevention is. Or how you can get physical therapists involved. Or how you can get occupational therapists involved. So there are these resources that, again, are on the Falls Free website. What I'd like to do is switch now to one of the 4 programs we're looking at, which is Otago. Otago is in both SIP 1, where we are trying to implement this in the 3 states, as well as some stuff that we're doing nationally. And we work really closely with Tiffany Schubert, and I think this is what I would call one of our success stories. And why it's a success is we're not just going to individual training, one PT at a time, but there's actually training courses that are web-based. And something like 50 PTs have signed up for Otago training in New York. This is how to go from retail, one-on-one, to wholesale, where you advertise in the PT network that these trainings are available. Y'all could even pop on, and they're incredibly, inexpensive. You get continuing medical education credits, and it's something like $25. But the online course is to train physical therapists to integrate Otago program as part of their practice. And why this is successful is that PTs already know about the importance of physical functioning. But what it does is it gives them a standardized approach, particularly around falls prevention. Remember, this is Tiffany Schubert, is the woman in the left. And so again, if you got on the web, you would see this course catalog. You'd see a picture of Tiffany and one of her clients. It's important to have training, but we want to know the impact. Can you do online training of Otago? Can you have PTs all over the country get trained? And how are you going to know it makes a difference? So we also now have a centralized outcomes database. So we want to be able to help the PTs and then to help ourselves as the evaluators to be able to track the patients through the program. Outcome measures are being collected, and we also want to understand the implementation process and what kinds of PTs are signing up for these programs. So you can see, here's a link. So what we have, if you think about it, is we have the online training, we also have the data training, but we have some archiving. So if you wanted to know how to use the data and you didn't make the first data training, it would be archived so you could understand how to access and use this outcome database and also collect and record data. Okay? So when we think about what physical therapists need, first they need to complete the online training. We want them to look at the archived implementation webinar, how Otago gets implemented. We want them to be able to access and understand the data and then log in. So all of this is sort of how we think that we're going to get hundreds of PTs across the country. And in SIP 2, our goal was to get something like 150 PTs to be doing Otago and then tracking their patients. We're actually probably going to end up with more. But I thought it was important just to get a sense of the kind of data. So you log in and you see there's patient information, there's a baseline survey, there's an 8-week follow-up, there's a 6-month follow-up, discharge survey, comments, functional measures. So you can just sort of see the kinds of questions that are being asked so that you can see the outcomes, the baseline survey about, how much the person has been in risk, how much have they fallen before. You can see that this gives you a good place to be able to track the different functional assessments. Okay, so that sort of tells you that we think that Otago will be a success. We have a mechanism to essentially train PTs and track data. So what are the next steps? If we're talking about that first SIP, the State Falls Prevention Program, we right now are in the pilot phase. So we want to move from the pilot phase where we've built the training infrastructure. So now there are trainers who know how to deliver stepping on, they know how to deliver Tai Chi, they're having some experience with Otago, some experience with Steady in these 3 states. So what's our lesson learned? You don't even have to learn this lesson. I think everybody knows that it always takes longer to build infrastructure than you would imagine. We thought we were going to get in and out of this pilot phase in a year. Well, we're sort of at the end of 3 years. We now realize we have the infrastructure needed to move forward. The evidence-based programs maintain positive effects. I think this is really important in translational research. That is, we chose the programs because in randomized clinical trials, they had very positive outcomes. What we're seeing is now taking this to the field in 3 different states, we're finding the same kind of positive outcomes. We're really pleased about that. There's mixed feedback on the value of data collection. As a researcher, we live and breathe data. In the field, these are people who are at YMCAs. They're people who are at senior centers. They're not used to collecting data. So the states are saying, don't make us collect this data. These are evidence-based programs. Other people are saying, yes, we still want to know if these programs are important. So I think this is always the challenge about when programs go to the field, they're widely disseminated, how much data is needed and data used for what purposes. what we're telling them is it's still important to do the time get up and go. You might not need that for data, but that's used as part of the program. Older adults love to see their score at the beginning of class. They love to see their score, their walking speed at the end of class. But what we realize is that how much data it is, it needs to be streamlined. So that's what we're working on, is streamlining the data so that the community partners don't feel they're in a research project. They want to feel as though they're in a service delivery program. And what about the policies, programs, and partnerships? Well, we are providing continual feedback to the state coalitions. What we see, I showed you the 8 goals, and what we see is most of the states, we did a survey about 6 months ago, are implementing multiple goals and strategies. So they're not just focusing on one. The one that people focused on first was probably the awareness, but they're doing many of those different goals. With Otago training and implementation, the online training is seen as valuable, as is the online database. I talked a little bit about the definition of who is an eligible patient, and this is the programs. Each of the 3 programs have in their mind the ideal program, a patient caseload, whether it's stepping on or whether it's Tai Chi, Otago, or whatever, and it's always appropriate to get people who you think can benefit from the program and engage in the activities safely. What we're finding is there's a huge overlap, so that in Tai Chi, you have some people with high functional level and some people with lower functional level. So again, challenging to have people at different functional levels in the same class. What's important, though, is a stable funding reimbursement stream. So the WISE right now are rolling out Tai Chi. It's part of the WISE offering. Otago and STEADY will only be sustainable to the extent to which the healthcare providers can charge for their services. And so we're working now how to get points and credit on quality improvement that's needed for healthcare providers. We have, and I didn't really talk about this, a community health worker curriculum. So the concept here is, particularly in border regions and regions where there are not a lot of healthcare providers, we now have community healthcare workers understanding the essence of falls prevention strategies, the importance of screening and referral. And we have a 3-session course of about 13 hours, which will train community health workers who are going into the home for a variety of reasons to be able to spot and interact and deal with fall risk. And there's been a lot more interest here than originally anticipated. This is the end of my formal remarks, and I think now, did you want time for questions? Here, the concept is if you're 65 and older, you get Medicare. So once you're 65, clients anticipate, older people, that these services will be covered. And so they don't necessarily want to pay, per visit. And so the concept is if a doc or somebody does a prescription about falls, actually they have changed. This is a policy change. The policy change recently is that you don't have to improve, because always before, PTs could only get reimbursed as long as the patient progressed. They finally realized with an older adult, you may not have progression and improvement, but you may have more maintenance. So I think the assumption for the PTs that it will work best if there is an insurance, meaning Medicare would pay for these visits. And it may even be a copay if you don't have supplemental insurance. But otherwise, older adults would be very reluctant to pay for PT. And that's what we're talking about with policy changes, is making sure that the payment reimbursement, in the same way that you would pay for different kinds of PT services, they want to make sure that falls prevention and evidence-based program is paid for.
So there's no,
This is the problem. You usually have traditionally so many sessions because it's very complicated, Lorraine, we can talk about this, but there's Medicare Part A and Medicare Part B, and you know, if you have a fall and you're discharged from the hospital, you get so many sessions, so it's very complicated. I think the important point is we're not yet where Otago would be reimbursed over the year. So the problem is the year length is usually longer than the traditional reimbursement. No, not in the US, but initially I think in New Zealand it was either nurses or PTs. But again, if you think about, you know, people are talking about home health aides who are going into the home and their ability to be instructed by PTs on how every time they're into the home, because home health aides would be there more often than a PT. We talked about that at lunch, and so for those who weren't there, I think there are incredible opportunities in IT, sort of technology to prompt people. So whether it is the phone call that prompts you to take your medicine, or the iPad that wakes up each morning and says, time to exercise, or the kind of things people are using now that are called Fitbits. So I think we need to explore the power of IT more so than just for the person who loves gadgets. So again, right now there's probably a slim group of people who are seeking IT. To make it population-based, we have to make it the easy thing to do and make it just like going outside traditionally and getting your paper. Every morning there would be something that would remind you. So I think the goal is to use IT to sort of thread through what happens when a professional isn't there. Other questions or comments? Yes. Do you know that's a really important issue about cognitive impairment? If Maria Fiataroni, and she's not here, is she? If she were here, she would say, in a nursing home, anybody can do exercises, and probably 80% of people in nursing homes have cognitive impairment. The thing about stepping on in some of these programs is there's a lot of talk and discussion and action planning and problem solving. But so in that sense, the person may not get as much out of it. You don't, I mean, I think that in these programs, if you have mild dementia, you'll get in. But if you have problems with orientation and problems that would keep you from working in a group, you probably wouldn't be able to get in. But I think that you're right, that we can't be restricting these activity programs to only people with no cognitive problems, because then we wouldn't be targeting the people at 75 and 80 who probably could benefit from the exercise pieces. It's been delightful to be here. Thank you so much for coming and listening and sharing.